Well, thank you, Ben. Good morning, everyone. Great to join you on a rather momentous day for the NHS. I'm Andrew Stephenson. I'm a former Minister of State for Health and Secondary Care in the Department of Health and Social Care, and it is my pleasure to be the facilitator and chair of this panel. 6 different people, and a very short time, so we're going to have to be quite pithy. I'm going to ask the panellists to introduce themselves when they start their remarks, and I'm going to ask the panel, if we can, to start off by each giving us one example of how they have delivered innovation through their own network and how they've communicated those learnings across the system. Can we kick off at the far end with Professor Mike Lewis? Can you introduce yourself and get the discussion underway?
Of course. So I'm Mike Lewis, Professor at University of Birmingham, which is handy, isn't it? I can just hit bait there for a cup of tea. My remit is I'm a scientific director working for Chris Whitty and Lucy Chappell in the Department of Health. And unlike the sort of security organization that has 5 eyes, I only have 4 eyes, which is industry, innovation, investment, and then just as a booby prize, I got intellectual property, which is one of the worst things to have. And I look across the whole of the £1.6 billion spend we have on research across the UK. And I'm not necessarily an NHS insider. My career was primarily in industry, where I worked in pharma and also in medtech, and living in the US, France, Italy, Belgium, and of course Switzerland. If you're in pharma, you have to do that, don't you? That's a really good question, Andrew. An example of innovation. And I thought, should we talk cancer vaccines, obesity drugs? Should we talk those? Or should we talk gene therapies? And I thought, no, let's talk something really, really sensitive. The innovation I'm really quite interested and proud of is the work we did with a group over in Nottingham, which was at a health tech research centre in Nottingham called Mindscape, and they came up with a digital tool for diagnosing ADHD in children. Why is that important? Well, we got hundreds of thousands of people waiting for diagnosis. The average wait for a test or diagnosis of ADHD is what you think, Andrew? How long?
A long time.
24 months. Yeah, I mean, that's time sitting there waiting to get treatment. So they came up with a digital diagnostic for ADHD, which is, they went through the whole panoply. They identified the need. They then went and designed some really good randomized clinical trials, which would test the hypothesis of A versus B. Is this as good as something else? And they developed it inside some NIHR infrastructure, which is a health tech research center that we fund. So the people we'd helped train as academics worked in a center, which was a place, working on a project which was really key. So when you go through all that, you say, okay, we've developed this wonderful thing. Is it being used? Is there an adoption of it? And that's the bit which I'm really pleased about. Because so far, these guys have tested 100,000 children, 100,000 children. The wait time where this is deployed for ADHD testing is down 75%. And for my £2 million investment, which I think I got from a guy over there originally, the £2 million investment, it's saved so far £50 million in NHS appointments. So it's made a real impact. And it's not just in terms of the child themselves. You just think about the burden it places economically and everything else on a family of not knowing what's going on. So from a societal perspective, from a need perspective, I think that's probably the one I'm most proud of.
Excellent. Thank you. Chris.
Good morning, everyone. My name is Chris Bird. I'm a project director at UH&M, so that's the University Hospital of North Midlands, based in Stoke. So perhaps not quite as close as Mike, but certainly not that far. In my role as project director, a large part of that is helping the organisation to develop an environment for innovation. So we have an awful lot of latent entrepreneurialism in UH&M. There are 12,000 people employed by UH&M. We have got lots and lots and lots of innovation coming forward. I think someone used the phrase about 1,000 flowers blooming, so it's a bit like that. It tends to be fairly organic in the sense that it's driven by everyday challenges that clinicians and professionals see in their clinic. And sometimes it's a response to funding that's available. What it is less is a lean into some of the major challenges we see as a trust, which are no different really, about different points of emphasis, but they're no different from all the other challenges that other trusts will make. So my role is to kind of bring some sense to that. And just, I guess, by way of example then, in terms of an innovation that as a trust we're particularly proud of, in fact, we've just submitted an article to the next edition of Chamber, actually, is about our adoption of the use of AI in our stroke services. So by adopting AI, our clinicians have been able to accelerate diagnosis. They've been able to make more accurate diagnoses and improve patient outcomes. And that also means, as a kind of byproduct, we're then seeing more people. So when you look at the stats, and I'll spare you all the detail, generally speaking, the stroke service in Stoke has outputs that are 4 times higher than the national average. So we treat 13% of stroke admissions with thrombectomy. It's 4 times higher than the national average. Our mortality risk is 14% compared to 50% nationally. And we've got 32% of patients undergoing thrombectomy who are discharged with no stroke symptoms compared to about 7% nationally. So that's not all exclusively about NI. There's a lot of hard work that goes in behind scenes, but just adopting AI has been able to really seriously change the game around that service for us.
Brilliant. Mindy?
Great. So we don't actually really deliver innovation. As you've heard from me before, what we do is we support those innovators within the system so that they can deliver it. But we also then help the system understand how they help those innovators deliver that. And we use quite a lot of soft power. So it's more about working behind the scenes rather than up front to kind of influence what's happening within the system. So it's things like connecting with the HINs to make sure that they understand, we've got innovations here, but then also connecting with industry. And a lot of what we do also is that kind of political work. So going in, speaking to ministers, speaking to people who actually make those decisions so that they understand when they're making decisions of what's going to happen within the system, that they understand what the innovators are feeling. So it's feeding back within the system what the changes need to be to make sure that the pathways that are created help SMEs and help innovations to be implemented. Things like the frameworks that are, I think CCS is here. We helped work with CCS thinking about the frameworks that they were changing and how that's going to affect the SMEs. And in some ways, we're going to cut the SMEs out. And then it helped them to make those changes and to think about it a little bit broader and come up with something a little bit better that supports those SMEs. So we don't deliver the innovations. What we do is we create the ecosystem or help the ecosystem do better with those innovations.
Fascinating. Paul?
Yeah, hi. So I'm Paul Henderson. I run the health and social care consulting team at IQVIA. And there have been 3 bits to my career. So a long time in the NHS and in social care, quite a good spell in the software and analytics industry, and latterly in the sort of change management space. So when I think about the things that I would talk to my kids about when they say, it's a bit like Friends, what does Chandler Bing do? I don't know if anybody watches Friends, it's quite hard to explain. So I talk about the development of patient-facing services, and one of the tests for innovation is how sticky is it? How do you sustain the transformation that you've achieved? And when I was at EMIS, we spent a lot of time developing patient-facing services, and when the pandemic came, and then after the pandemic, it was interesting to see there are all kinds of problems with the digital relationship between the care system and the citizen, but actually it's a lot better than it was. And the ability for people to book repeat prescriptions, book appointments, message GPs, get apps, look at their self-help, and there's a lot of work that's been done in that area, and being able to deploy that over a platform that was in 66% of GP surgeries was a really important way of landing and scaling innovation. So that's my what does Chandler Bing do story.
Excellent. Paul.
Yeah, I'm Paul Birch. I currently work for Northamptonshire ICB, but we'll see how that goes. And with Northamptonshire, I head up our population health and our data team. And in terms of the innovation, I think when I looked at this, what I wanted to talk a bit about was how we took an innovation and what we had to wrap around it to make a difference. So we took a fairly simple innovation, which is portable AF reading. Just put your couple of fingers on a couple of bits of metal and it gives you a number. That was the innovation. But when we broke down what did we want to do with it? We had to put together a lot of things. So we put together some of our data and some of our understanding. And from that, we knew that we've got a group of patients who don't attend for our health checks. They're less likely to get COVID vaccines. They're less likely to take up our preventative care offers. And actually, those are often patients from our racialised communities, often patients from our more deprived areas. And they also don't go to their GP that often. In a lot of cases. So what we put together was a clinical team to take that technology out into the community groups, work with community groups on delivering that, and just go to them in their place and do the testing. And the testing was really successful. We did about 500 people were tested. 5% of them had atrial fibrillation. None of them knew that. 45% of them had hypertension. Some of them knew that, some didn't. Some of them had been diagnosed and then sort of dropped out of treatment. But with all of those, they went away with a blood pressure machine to take that forward. We found 10% had also other cardiac symptoms. But what we had to wrap around with that was, it's great doing that test and seeing what comes out of it, but you need a clinician to look at it. You need that to be reviewed. You need a pathway to move that on, because one of the things when we talked to our GPs about it, they said, we don't want hundreds of people with white coat blood pressure measures coming to us. So we had to wrap that around to make it safe for GPs. But ultimately, and this was a bit the deal with the community groups, they were saying, if you're coming in, you've got to add value. And I think that innovation at the heart of it allowed us to come in and add value. And the bit that really made a difference wasn't the machine, it was the NHS people, the nursing team coming out to the group and engaging with them. That was the biggest difference. Yeah. But we wouldn't have got there, I don't think, without the innovation to drive that forward.
Great example. Tim, haven't got a clip-on mic, so...
Yeah, I'll do my best with this. Thanks, Andrew. My name's Tim Ringrose. I'm a kidney doctor, and I'm founding CEO of Cognitant Group, a digital health company. And we've developed a patient education platform called Healthy Note. And our focus is patients or people with long-term conditions, which makes up about 40% of the adult population of the UK. And as Paul's just mentioned, often people have multiple long-term conditions. But the innovation I'd like to focus on, if you'll forgive me, and well, I'd like to talk about kidneys. And did you know that today's actually World Kidney Day? There's a day for everything, of course. But kidney disease affects over 10% of the population, so about 7 million people in the UK. And it's one of these conditions that is not getting enough attention. Of course, if you have kidney disease and you end up having kidney failure, it's a traumatic, devastating thing to happen. You need dialysis or transplant. But in fact, a bigger issue is that if you have kidney disease, it brings along a lot of other risks. You have a 20 times risk of having a stroke, for example. So diagnosing early, that's a theme that's coming through here, and then intervening is a really important thing to do to prevent people being diagnosed late and having unnecessary complications and cost to the NHS. So the innovation that we've done here is we've been working with the West Berkshire Kidney Unit to develop a patient education program for patients at the early stage when they've been diagnosed with kidney disease, to explain what does that mean, what tests should they be having, what drugs are available, and what lifestyle choices they should be making, and that can have a real difference to the progression of their disease. That's worked really well. We've got great feedback from patients in terms of usability and that they've learned more about the kidney disease and they're making a difference. And most importantly, given the funding issues, we've also been able to work with the renal unit there to massively increase the efficiency of the clinic. So there's been all patients, and only 30% of patients in that clinic are now seen face-to-face. So remote consulting using our education platform has made a big difference there. And we're now rolling that out to other ICBs, and I'm pleased to say that we're working with Birmingham and Solihull, who are now adopting the programme. But one of the big issues really is around, as I think it's been mentioned, it's not just about the innovation itself, it's how do you work with the workforce and the system to really to drive the benefits.
So some fantastic examples there of where we've seen real good innovation adopted into systems. If I can come back to you, Mike, that is the challenge. You must every day see brilliant research-led initiatives. And then it's how do they actually get adopted into the system, the barriers, and how does that then translate into real benefits for patients? So perhaps if you could kick off a discussion on how we go from the brilliant work that you're doing through to the adoption that a lot of people have talked about.
I'm not going to take credit for all the science, okay? So, we are brilliant at science, aren't we? I mean, we do the best research in Europe. We're in the top 3 for research in terms of publications and papers and 4-star publications. We can do brilliant science. Innovations, you're right, we can do brilliant innovations, and there's so many ideas coming out in terms of things which are patentable and trademarkable, and we're really good at that. Now you're sort of waiting for the but, aren't you? Because I'm not sure really whether ICBs, and I'm talking to you now guys now, I'm not sure whether you guys know what is happening in the world of research. I really am not sure you know, because right now I checked the numbers before I came in, I've got 5,000 clinical trials across the UK running. How many do you know about? In terms of patients we recruit about 1 million patients a year. That is about a Wembley Stadium every month. And probably since we've been talking here, we've recruited about 22 patients onto trials. Now, how many of those do you know about? I think one of the challenges, the barriers we have is that R&D doesn't feature high enough in terms of the ICB agenda. I tested this hypothesis yesterday in Nottingham because I asked the guy from, I won't say which ICB he was from, okay? He was from somewhere in the northeast. I asked him, I said, who's your R&D person at the ICB? He said, I don't know. And this was one of the guys at the ICB. He said, it's probably in my area. I said, what do you mean, probably? So there's a real focus there. So the first thing is awareness of research. You have to work out who's in charge of research. And I think it's mandated for ICBs, ICSs. It's part of your remit. But when I look through ICB reports, I don't see too much on research. You don't know what's coming next. You're not horizon scanning on the research, so you're not aware. Second thing is, just in terms of, I've been a little bit pointed here today, okay? In terms of adoption, you have to get over the fact that different ICBs are not unique. The genome of a person in Northampton is the same as a genome of a person in Birmingham, Solihull, okay? Patients are the same. The condition expressed, COPD is no different in Birmingham than it is in Stafford. The treatment, there are no specific drugs for COPD patients in Northampton versus whatever. The patients are the same. But we have this, so does anybody remember the Martini advert? Anytime, any place, anywhere. Well, when innovations come through, it seems that every single place has to test it every time, every place and everywhere. There's this whole thing, I think you have to get over the fact that if trust A says this is okay, and it's a good trust, then it's going to be okay for you and you can adopt it, so you can accelerate. If I can find one cure for a disease, I'm trying to find a cure for the disease for pilotitis. Third kick, if I can go for the third one. You've got a cultural job to do as well. Wes grabbed me in the lift and he said to me, he said, why are academics so sniffy about working with industry? I thought, that's quite a cool one. Because research, whether it's commercial or non-commercial, research is good for patients. It's good for staff. And it's good for economics as well. So why wouldn't you be doing more of it? There's so many papers, the RCP, Yonka, they put out so many papers to say research-intensive places have better outcomes than non-research-intensive places. So you should be looking at these things and looking at doing more and more research, which will then create a culture so that you can adopt the things that you have a look at. So you have to get really, really used to the fact that research is here. And as I was looking at the breakfast tray this morning, about 7 o'clock before a call at 8 o'clock, and I was just looking at the breakfast tray, which is spread out, and I saw eggs and I saw bacon. And I thought research is a bit like breakfast. You have to be more like the pig, because they're committed to it in terms of your breakfast ingredients, than the hen who's just involved in it slightly. You have to become the sort of crispy breakfast item about research, okay? And you have to build that culture in.
Thank you, Mike. Chris, from a kind of hospital trust point of view, what would you say are the biggest kind of operational and cultural challenges you have to overcome to deliver innovation that's really going to benefit patients?
Sure. So there'll be absolutely echoes of what Mike says in what I say. So I'll confess, I was feeling pretty smug on the way in this morning, actually. I'd done my prep for today. I knew what I was going to talk about. The traffic was flowing, at least for Birmingham. All things are relative, aren't they? The sun was shining, or at least it wasn't raining. And I thought, today's going to be a good day. And then Reid Hoffman was interviewed on the Today programme. I don't know if anyone listened to it. So Reid Hoffman, I'm sure it'll be on BBC Sounds if people want to go and check it. He's the creator of LinkedIn, and he's kind of forging the way in AI. And I thought, my God, he's just turned everything I was about to say on its head. Because the premise of the question is about how we address the barriers. And what Reid Hoffman was saying was, the future you need to design needs to be a good future and not one that just avoids the bad things. And I thought, okay, so I'm going to need to think about that. And part of that thinking about it is verbalising it to you guys and bringing you into that conversation. But I guess going back to kind of us as a hospital trust, as I said earlier, we're not grappling with anything that any other hospital trust won't be grappling with. Demand, funding, workforce. And there'll be different points of emphasis, but a combination of those three things will probably keep most hospital folk awake at night. There is a tension, though, I think, with the national policy landscape, now not least of which what's come out today, but demand, funding, workforce consumes resource, energy, focus, effort. Where do we get the headspace to focus on care closer to home, analog to digital, sickness to prevention? Where's that coming from if it isn't coming from innovation? And can I honestly put my hand on my heart and say that innovation is as prioritised within our trust as it could be? Probably not. That's not to say it isn't happening, as I said earlier. So my role, if it's about anything, is about changing that paradigm, really, in our trust, so that innovation is seen as integral to the response to the challenges, rather than something that someone does, when they've got a spare 10 minutes between outpatient appointments. There's a whole load of subplots in that, as I'm sure people will be familiar with them: routes to funding, capacity and capability, both in terms of headspace, but actually access to the right skills and experience and expertise to support innovation. And then what I've called a series of misalignments. So trust, generally speaking, tend to be risk averse. It's not necessarily the environment for innovation, is it? There's usually a requirement for an immediate return on investment, whatever that return is, whatever currency you're using to define that. Again, it's not generally where we're at with innovation. And then picking up on Mike's point, I think I have more traction with colleagues when I'm talking about how I can help them develop their new idea than I do saying, this is a good idea that Newcastle Trust had, how can we put it into UHM? So that misalignment between the new and the adoption, I think, is a real issue. How have we done that? We've set out a series of what we're calling 5 mutually reinforcing platforms. I won't go through them all in detail in the interest of time, but happy to talk to people about those. So strategy, what do we think innovation is? Why is it important to us, and how can we lean into it? What are the big challenges we see innovation as supporting? What's the framework? So we've got an R&I team. What's our end-to-end offer to those people who do want to explore that innovation space? How do we support them? How do we draw down the support that's available through others? Creating a network, so really early visibility. A lot of our innovations are born out of discretionary effort by medics. They come to us 3, 4, 5, 6 months down the line. We've not then had a chance to align some of those corporate support services around finance and digital and governance, etc. Getting our interfaces right, internal interfaces. So we've got quality improvement, we've got transformation team, we've got a research team. Innovation sits as part of that kind of plurality, but we've not got those interfaces right. And then finally, just about the collaboration, whether that's with other NHS partners or organisations such as the Accelerator unit and the HIN, before we even get into kind of universities and industry. So that's our kind of framework that we're putting out into the organisation to try and build some cohesion and coordination around addressing those barriers.
Brilliant. Mindy? Of course. Now, Mike and Chris have just talked about some of the barriers and some of the key challenges that, of course, the Innovation Accelerator is there to address. So, kind of, what lessons have you learned from kind of addressing some of these challenges in different parts of the system?
Right, I just want to say first of all that Reid Hoffman also did a thing on The Rest Is Money, and it's probably one of the best interviews I have heard. So honest. Other podcasts are available. But I can second what Mike has said about that pilotitis. I think one of the biggest barriers at the moment for SMEs is that you can pilot, you can prove yourself over and over and over, but there's no clear pathway to say that if you do this, you will get this. There's no contract at the end. There's no, and a lot of the times it's because there just isn't that funding. So it's almost like someone, hopefully the government, can come up with a pathway to say, this is what we expect. These are tick boxes we would want from innovators and innovations. And then when you get all of this, when you've fulfilled all of this, we will offer you a contract. And it doesn't need to be national, because I think it's quite hard to implement something nationally. And I'm always a little bit skeptical about doing one innovation nationally, because I think there needs to be that competition in the system. But at least within 4 or 5 trusts, so you're sustainable, because a lot of SMEs fail because they don't have that money coming in. It's not constantly revenue generating. And by the time you get that NHS contract and then you finally get them to pay, you might just be at the point where you're on the brink of collapse. So it would be great if the government could work towards creating that pathway. And if the government isn't going to do it, who's going to do it? Can the ICBs come together and create something? Because there's got to be funding for these at the end, and there's got to be a promise that you will be taken up for innovators.
Great point.
Sorry, can I just also add, Tim mentioned about that, what are the lifestyle changes that people need to put in place? I think if we are going to look at it as a whole pathway, we need to think of public health too. I think that needs to feed into it quite extensively. So that pathway can't just be for an innovator to go into secondary care or primary care and they do A, B, and C. They need to actually show that within public health, everybody is feeding into that. So it needs to be a system-wide approach.
Yeah, very much so. Paul, obviously, real-world data and evidence generation is going to be absolutely critical to ensure that not just innovation happens, but the right innovation happens. Do you want to say more about how you worked on projects like that and how you could help?
Yeah, thank you. So I think there's a narrative that the NHS is broken, but actually the real world evidence is the NHS is really good actually in lots of different places. You know, Tim gave some great examples there. And one of the things that the NHS does increasingly well is it understands the demands of patients with conditions. It segments them into groups, it risk stratifies them, and it streams them to different points of service delivery. And it does that really well. But actually, the contrary evidence says if you start with people and work back, you get a kind of different view of the world. So not every person is a patient. People have a set of challenges. So we run, flying the flag for North East Lincolnshire, where I live, we've got a children's kidney disease charity, an international charity run by a lady who runs in quite a deprived area of town. She feeds parents with hot dogs on a weekend in a park. She does all kinds of things. And what she's trying to do is address the challenge of having children with kidney disease. And those challenges aren't necessarily health-related challenges. They're as much social care challenges, and they're contextual challenges. And they are challenges with trying to get a GP appointment at 8:30 on a Monday morning, going to A&E because you know that you might have to wait, but they will help you and not turn you away. And, I'm just thinking about that. And when you think about the real world evidence from that perspective, you might come to a conclusion that actually what we need more of is sort of precision public health. So we talk about precision medicine, and the health and social care sector is one of those areas where it's actually probably cheaper to give somebody a made-to-measure suit than an off-the-shelf one, because we waste so much in the system in trying to provide those services that we shoehorn people into. So understanding those needs and where there is reversible risk in your population means that you have a chance of designing more holistic services. And I think if you're in that situation, you're then able to have a better dialogue to the challenge that you were just reflecting really about. we've got this narrative of let's fix the acutes and let's pour money into the acutes. But actually, we've got the 3 government priorities, one of which is prevention, another of which is sort of is being out in the community, and how is that being followed up? And your challenge about pilotitis and how you scale things, you scale them by having an evidence-based conversation, often rooted in the demands of the population that we all exist to serve, rather than thinking of everybody as a patient. And we just completed, the final thing I'll say is that we completed quite a large citizen engagement project for an ICB recently. And they're in a situation where if they carry on with their current care delivery model, they're going to need 600 beds in 10 years' time. Good luck with that. That's 2 hospitals. And so that their model says we need to move from a bed-based view of the world to a community contact in strong neighbourhoods view of the world. And how might we do that? And I think a lot of the innovation that we have and that we see might be fixing a point problem, but actually how do we get it to contribute towards the overall societal problem so that it has a material impact? And Jim spoke about the influence of life sciences firms. They want to invest in UK PLC. So we say there's no money, and it's difficult to have that conversation today of all days, but the NHS does spend money, and it has the ability to attract money. So somehow what we've got to try and do is use that evidence to tell a different story about how we can deliver social value and then value for the care provider organisations. And I think if we do that, the evidence will support us in landing innovation more successfully.
Thank you, Paul. And Paul, picking up on what Paul just said, kind of thing, but also what you said in your example at the start, talking about working with community groups. How do we ensure that innovation isn't just adopted by the system, but how we ensure that it's targeted at health inequalities and addressing some of those patients who are most in need?
Yeah, and I think we're in the NHS very data rich. I think it's not that we don't have the data about people, it's often that we don't use that enough, and those shifts, for particularly that preventative shift, is the key challenge I think that we've heard there. There are challenges with that. By and large, the iller you are, the more we know about you. And what that means is often we have blind spots, and the more you use health services, certainly the more that we know about you. So I think we have to be mindful of those blind spots, and we have to look for them and think about how we work and address them. And we also have to be realistic about the capacity of clinicians, because we can see this with a number of those areas. 80% of GP contacts are with people who've already got a long-term condition. We don't, as a system, actually do very much with people who don't have long-term conditions, and we need to find ways of turning that around. And that probably won't be through GPs or qualified clinicians. And I think that public health bit that's been raised a few times, I think it's the right thing. It's probably the wrong term, because it's actually a treatment, and it's an active treatment that helps people who have long-term conditions as well as those who don't. It's how we lever those other elements around it. And I think that just in terms of getting on top of that data, I think we're not going to do that analytically with people. That's going to be the areas where we are looking at the generative AI, where we are looking at the machine learning, and we just have to move on and get into that space. But I'm not sure that enough places are there. But be mindful that for things to change, somebody has to do something. That might be the patient, that might be a clinician, it's probably both, but we've got to think about the end point and what changes will benefit health for our populations.
Great. I'm going to throw it open to questions in a moment. I'm first going to come to Tim to give your kind of final thoughts before we throw it open on digital innovation in particular, and how we can use digital innovation to empower both patients and clinicians, and how we're ensuring that those technologies are accessible, equitable and scalable.
Thanks. Well, it's hard to know where to start. I think what I didn't mention before was that I'm part of the NHS Innovation Accelerator, and that's a really useful group to be part of, although sometimes it does feel like it's a self-help group of addicts trying desperately hard to help the NHS, and the NHS just keeps turning its back on you, and other people are telling you need to go abroad because there's no point trying to solve the NHS. But I think it's worth it, and we're very committed to it. Introducing a digital innovation, makes a lot of sense because we're all using our smartphones. We've all used them multiple times today. We've used them to find out which hotel going to navigate there, to buy our train ticket, pay for parking, etc. So using our smartphones for our health makes total sense, and yet we're still at the very early part of being able to do that. The NHS app is fantastic. I think there's over 30 million people actively using the NHS app, and it allows you to do more and more. And I know there's an initiative to layer on more treatment. But I think there is an important point to think about health inequalities, in that I think it's already been shown that those who need the help most are least likely to be able to use the NHS app for various reasons, language, health literacy, etc. So I think my point really that I'm getting to slowly is that we've really got to have a big focus on health inequalities to really have the impact with initiatives. Digital can be a big part of that, but of course you've got to think about digital exclusion as well.
Fascinating. Thank you. Now someone's going to come and grab this microphone because that is also our roving microphone. So questions, I can see the first hand up is the gentleman there.
Thank you to the panel again. Mark Raja, C2AI. First of all, a day's a long time in politics, but it seems like a day's a long time in healthcare as well. I don't know if you've just seen on your feeds that NHS England is no more. So RIP NHS England. I suppose the question to the panel is, we've been talking a lot about innovation, and I know in the last panel as well. But the reality is there isn't enough money in the NHS. So is the question really about what we should stop doing that is not adding value in order to do the things that will add value? To give you an example, NHS England in their last now public board meeting said there was going to be a 3% compound growth in demand over the next 10 years. That equates to a 40% increase in demand. That is unsustainable. Given the barriers that we have in terms of increase in funding in a recessionary environment, what are the things that we're going to stop doing in order to do the things that are going to be innovative and produce value?
Great. And if you just hand the microphone to the lady in front of you, but hold fire on that, we will get some answers to the first question first. Mindy, do you want to kick us off?
I don't have an answer to what it is we should stop doing. I think one of the problems we have within the NHS is the lack of decommissioning. So everything keeps being piled on and piled on and piled on, and things just don't get stopped doing. And I really feel like that's probably, it's not just what do we need to do, but it's what do we need to stop doing, it's how do we do that. And I think there needs to be a real focus on that. And it's probably one of the things that will save everybody money at some point. But we all need to come together to figure out what that's going to look like. I'm sure somebody else will talk about what innovation to say no to.
Chris. So I think it's a really good question, actually. I think it picks up on some of the things we've been talking about. And there are a whole range of diagnostics we can use around that, GIRF, model hospital, so on and so forth, that will give us the ideas of where we can stop. I think there are areas where we could do things better. So a colleague was talking about digital transformation, and I was thinking about how that helps with kind of that model of care is better for patients in terms of ease of access, better for the environment because it avoids car journeys, probably empowers patients to take control of their own health in certain respects. So I'm sure there's things we can do. I think the key for me, though, from a hospital trust perspective, again, channeling Reid Hoffman from this morning, is probably less about what is it we're going to stop doing and what are we going to start doing. So there's a bit of an inconvenient truth, I think, this risks being controversial to a certain extent, is that we could be as efficient and as productive as possible. It will not meet the demand that's coming through our doors. It just won't. So we cannot be the hospital on the hill that is ever more efficient and ever more productive, whether that's stopping doing things or doing things differently. The answer for us has to be reaching beyond our hospital borders, working in partnership with other system partners, industry, universities, etc., to positively influence those future patterns of demand. So I'm much more interested personally in that conversation and that partnership collaboration piece than perhaps stopping doing things.
Okay. Paul, do you want to say something?
Yeah, I'd just say that, so there's 70 trusts in the UK, England really, use our patient level costing software. And so what that enables you to do is look at every single transaction in an NHS trust. And there's been a long industry, largely led by the big four, that go into an organisation and go, charge more for your car parking, how much are you charging for your ultrasound pictures, start your theatres on time. And I'm sure we've all been in those kind of conversations. And you can get some marginal gains from that, and those marginal gains are quite important. But there's a fundamental shift required, as you were just saying, around organisational design, really. So you say demand's going, but demand is going for a model that might be broken. And actually, if the model was changed, the demand might be spread across a different surface area and might not actually manifest itself in such a way. So so I make the point about marginal gains, point about service model, and the third point I make is about attracting investment. So, Jim spoke earlier on about the life sciences industry that wants to come and invest in UK PLC. There's money on the table for us to do that, and we're not taking it. So I think we kind of have to ask ourselves why that's the case.
I think what you've just brought up, though, is there's like a real elephant in your room. Every time I speak about this, there's always some adversity within the UK population to private. There's our NHS, don't bring private in, they'll come and take over. What people don't realise is there's so much private running through the NHS already, but it needs to be almost a culture change within the UK to say it is okay to bring these in because it'll be better for our healthcare. So we need to somehow figure out about the education of the public. I almost feel like you need to start doing it from really young. So it might not be my generation that'll change, but the really small ones will be like, yeah, it's fine, bring in Google, they'll be great. And I think that, that's for me, feels like a really important culture change we need to do.
We'll try and bring in as many questions as possible. Mike, are you happy to hold off?
I'm happy to hold off.
Okay. Next question, please.
Hiya, thanks. I'm Helena. I'm the Innovation Lead at Humber North Yorkshire ICB. My question kind of brings in a few things we've talked about. We've talked about being really data rich in the NHS. We've talked about the quality of research in the UK. We've talked about pilotitis and all of the data that must be sitting there from pilots. How do we mobilise any of that into actual insights, knowledge, and how do we get that to people who make decisions? Because for me, that's where the link is really missing.
Mike.
I'm Professor of Life Science Innovation. I've got no idea how he qualified to be a person who's in charge of innovation. Nobody I spoke to so far who's got the word innovation in their job title can point me towards a degree or master's course they did in innovation. We don't teach innovation. We don't understand innovation. That's understanding the evidence behind the innovation is really key. I need to trademark pilotitis as well, just before we finish, just because that's coming up. Going back to the first question as well, what do we have to stop doing so we give ourselves a headspace? I think we have to stop thinking institution-centric, and we have to start thinking patient-centric. We have to stop thinking about real estate-based care, and we have to start thinking about care where the patient needs it. The research takes place where the need for research is. The care should take place where the patient is, and we have to do a lot of that. My daughter's an ED doctor. She's actually an ED surgeon, and she is sick of seeing people with late-stage bowel cancer coming and presenting, which presents an enormous cost barrier, and the money's sucked up doing that rather than doing early diagnosis on patients and finding the cancer earlier. We do 1/4 the number of diagnostic tests they do in Germany, France, and Spain. And I challenged a doctor about this yesterday, and he said, yeah, but we order the right tests. I said, no, you don't, because your cancer survival statistics are poor. So we need to do more tests, we need to start investigating more, do more investigations earlier, but not do them in a big institution that people have to drive to and talk about parking charges. We need to do it where the patients are. And if you can do that and break that cycle, you will find you will have the money to do the things that you need to do.
Anyone else on?
Yeah.
Yep.
I think there's something about the innovations which often defines around the clinician's problem, and I think we need to think about the patients and the patient's problem as well, and look at outcomes over a longer period of time. So I think in that question about value, we're not very good about value, but one of those things that we have is not just the thing that research might look at, which is what happens quite soon before or after an intervention. It's that longer period and what difference it makes, and be thinking about what we're trying to do as the NHS, which is improve health. But we know those shifts are the right challenges because we don't always know how what we're doing is the best way of improving health. So I think building an evaluative approach and a thought of value into all that we're doing, and helping put a longer term perspective on that innovation because I think that's often the barrier to uptake for us. You can see those short-term benefits, but what happens next? If we can add that to it, I think we add even more value when we make that innovation a much more complete package and something that will be more attractive to the commissioners because they understand that.
So just a quick one. So on behalf of the residents of the Humber, thank you. So a little while ago, I ran a data science team, and they've all gone, and they're all rich as Croesus now. And where they all went was into industry, building recommendation engines for retail, shopping, other sectors. And what they did really well was they latched themselves onto innovators and entrepreneurs and found a way of connecting the great science with the general public. And that's what they got reimbursed for. And I think part of the challenge that innovators face in the health sector is that we don't think about what's the recommendation, what's the next action for the person that's consuming this information that we're generating. And if you, we do quite a bit of work with AWS in our business, and they work back, they are obsessed with the customer. And if it doesn't add value to the customer, they don't do it. And some of that thinking, I think, in the innovation landscape, I think we do well to try and adopt a little bit more of that. And there are pockets of it. It's not bad, but we could do more of it.
I'm going to bring in Chris, and then we're going to go to the next question. Chris.
Yes, so just 30 seconds, because I think so post-event analysis, for want of a better collective term, I think is often neglected, actually, and the extent to which it's done is often an afterthought to say, let's see what impact this has made, rather than something that is designed into the very start of the pilot. And I won't use that term, but we can all think of pilots that have effectively become BAU because they've just never stopped and they've been running and running and running. But that's not on the basis of any kind of evaluative evidence. Yeah. And I think both Mike and I talked in slightly separate ways about some resistance to adoption. Actually, having really clear post-event analysis and evidence is one of the key ways of being able to cut through some of that.
Great. I was going to take a question from the lady here.
Thank you. Angela McFarlane from IQVIA. I just want to reinforce some of the things that Mike was saying, and I want to build on some things that Paul was saying. Reinforce. We bring in 1.2 billion of economic investment every year to the NHS, or to UK PLC, through the commercial clinical trials that we bring to the UK. When Mike was pointing out about the mandate for research to be embedded within ICBs, you're absolutely right, it's not happening. It should be BAU. We talk about the clinical benefits. We know that patients that are in clinical trials do better, whether commercial or academic, do have better outcomes than those that are not. And we know that hospital active research hospitals have better outcomes for their patients than those who are not. So, that's the for good thing. But think about the finance, and people saying there isn't enough money. Well, you don't know how to make the money. Paul's already talked about what life sciences want to do. Why do the directors of finance not hold the research and development directors to account for the research that they're attracting to their hospital, be it commercial or otherwise? So we need to kind of shift that mindset and get it embedded. And why are these R&D directors not on the boards? So enforcing what you're saying. The next thing, Paul, I want to build on something that you said about, the brilliant data. And the UK, we all get off about the brilliant longitudinal data, and it is great. But for a data organisation like IQVIA, it's absolutely bloody useless until you can make it research ready and actually fit for purpose. Did you know 90% of our data is unstructured? And 80% of it is never used. And yet that's where the richness of the data is. So we need large language models to be able to address that challenge and really bring out and actually have something that is of sovereign value.
I think the total as well is you bring in 1.2 billion, overall industry for clinical trials brings in 7.4 billion. To put that into perspective, that's about 100 F-35 fighter planes. Yeah, because that's how government's thinking right now.
You've been given the microphone back. I'm not sure if that's because you indicated you want to speak or on.
Well, I suppose I could go back to the question about what should we stop doing. And it's so great that themes of prevention have been coming through and going to the patient. I think what the NHS needs to stop doing is waiting for patients to become ill. because that's the whole way that the NHS has been built since 1948. And yet we're missing such an opportunity to intervene early. It is very difficult to introduce innovation to the NHS. It sometimes feels like it's a crystal maze where you think you've cracked the code, you've got through the door, and then you find that there's another puzzle for you to solve. But I think the prize is worth it, and that if we can shift that leftward, if we can shift upstream, so that the NHS can be much more about personalising and prevention, then I think we have a shooting chance of not just spending more and more money trying to get faster horses instead of saying, let's do things differently.
Brilliant. Let me grab that back off you. We've still got time for more questions. So we do the gentleman here and then the lady there.
Should the implementation of structured and systemic problem-solving tools and techniques continue to remain an aspiration for many primary care providers?
I can start on that. I think it's quite a complicated question. I think getting that right in primary care is really important. I think we need to think structurally about what primary care is, what role we're doing with it. And that's something we're doing in Northamptonshire at the moment. I think one of the challenges we're small. We've got 60-ish, 63, I think, practices. That's a lot of different organisations to work with, and you probably can't expect each of them to do that. So we're thinking structurally about what we want primary care to do. We're developing a model which is based on need, which will probably mean that different people will get different service depending on their level of need. And we're also saying to general practice, we want you to be doing more long-term condition management. And that focus is some of what you have to do. I think we have to set some of the terms for it and then allow the practices to problem solve within that and give them that help. As a ICB, we've seen our admission rates for over 75 drop pro rata each of the last 5 years, when in most other places they've gone up. So we know that if you focus on and we've not done that through direct treatment, a lot of that has been done through preventative care, and it's been effective. But we have to do that across the population. So yes, we do within primary care, but I'm not sure that GP practices individually will do that without support. So I think that's our role in the ICB or whatever comes next to support them to do that.
So it's a culture of opportunity that also exists in the main hospital trusts too.
Yeah.
To empower people to be able to problem solve at all levels.
Yes. Yeah.
Mike.
I think we just started to fund some patient recruitment centres for primary care as well, and God bless you for doing research in primary care. It's about 25% less to run a trial in primary care than it is in secondary care, so it makes us more competitive. The data access you have with systems like EMIS and TPP, you've got access to more data on ethnicity and everything else than they do in secondary care. And you see 350 million people every year in GP. They see about 8 in hospitals. You should be the place where we do more and more trials outside that real estate. And you should also think about partnering up with people like Boots or whatever other pharmacy you've got in your high street, because they can also deliver patients as well and work in partnership with you.
Yeah, as an ex-EMISer, you'd expect me to say I love primary care, and I spent a lot of time in GP surgeries looking at how they've been transformed. So, primary care was the first to try and enable people to operate at the top of their license and disaggregate jobs and tasks across different grades of staff. It was the first to adopt at scale patient-facing services applications. It was the first to start doing some day surgery in GP practices. Those practices are businesses, and they run on a viable basis. So there's a ton to admire in primary care, and the people that I sort of come across in my daily life tend to be giving their time freely because they don't get paid when they get involved in other pieces of work, and they do it because they're really, really passionate about what they do. And I think the trick is, how do we tap into that and get that organised so it can have a conversation at scale with life sciences? To your point, it's really easy to go and talk to United Leeds Teaching Hospitals about a piece of work because it's a massive organisation. It's more difficult to come out to North East Lincolnshire and talk to all our fantastic GPs that we've got in our area.
Yeah, we recruited 3,000 patients to the the mRNA flu study through primary care. We recruited 2,500 patients to the Novavax norovirus study through primary care. We tried to do it through hospitals, and they said, "Yeah, well, maybe we'll get around to it." We went to GPs, and they delivered. Yeah.
Yeah, and they deliver the service model
Yeah,
off the back of it as
absolutely
well,
right, yeah.
which is really...
So we've only got time for one final question, so I'm going to hand the microphone to this lady.
Hello, my name is Tanya. I run a digital health startup called Adagio VR. And I had a kind of exactly a perfect following question from this, that primary care is really a place where there is maximum opportunity to also hit all of the care outcomes we're looking at in terms of prevention and early intervention. However, it's also one of the most fragmented, institutionally fragmented parts of the ecosystem. And one thing when we've been engaging with ICBs that we see is that institutionally there is so much crisis that, yes, we can say, yes, you should be looking at data, yes, you should be looking at research. But I can see these doctors and these very, very dedicated public health professionals who they have no cognitive capacity left. And any of it is spent on making sure that their doors don't shut, which on the other hand, you see very large commissioning contracts being put out for not very effective services that, traditional service providers are kind of plugging and playing their procurement processes through. So what I'd like to introduce as a question and also ask, how do we actually do that innovation and enablement at that primary care level in a way that doesn't, and hopefully in a way that doesn't, or at least alleviate some of the crisis that I believe that they're experiencing at that ICB and primary care level, which, the amount of cultural change, staff overhaul and whatever else transformation that they keep going through, I don't think it's effective for them to be able to deliver their basic requirements, let alone engage with innovation, which is really difficult for us. But I think fundamentally also the patients love to hear.
Yeah, I'd agree with you. It is really tough. It's a bit like tapping on the shoulder of someone who's trying to resuscitate a patient, saying, I can help that patient I could have helped that patient get it in the first place. It's very difficult. I think what is helpful though is to look at examples of success. And if you look at companies like Accurix, who very successfully introduced a text messaging system into primary care and look at how that worked, whether you like them or not. So I think there are some success stories. I think it's really important to be very clear about what problem it is you're solving, because as innovators, we tend to revert to thinking about our product and why our product's great, but you've really got to keep focusing on what's the problem that we're solving and how are we going to be able to demonstrate that.
Yeah, and I think primary care certainly is in the right place to do secondary prevention, and it's a massive role to play in it. I think when you start thinking about it, doing more primary prevention, the important thing is building the networks and placing that within the community and the neighbourhoods, because people won't be coming to primary care that much. It's a lot what happens outside of the building. And I think that is the place where the digital tools, that relationship with patients that might be with the app that was talked about is important, but it's also the voluntary sector, the community groups, the infrastructure. It's linking primary care in with those. That's when you get effective. I don't think primary care can do that task on its own, but we have to build the platform out to the patient, which might well be digital in a lot of cases, but also work on the community environment that they're living in, and living in 99.99 times not in contact with health services. It's then when the difference is made.
Chris?
Sorry.
I think it's more about the fact the institutional instability that's happening at ICB level makes innovation harder.
Yep.
And how can we solve that so innovators can actually, there's actually space to be heard, and then we can do all of our problem solving or targeting, but when you have to fill a deficit in a budget or continuously have staff change, that bit is something as innovators that's kind of not our role.
Well, I'll bring in Chris and I'll bring in then the remaining panelists, because this is our last question, so it gives them a chance to sum up. Chris.
So I'm just going to step back from primary care as a element of provision and just build on the point you made, because so if I think about the trust that I'm in, as I say, 12,000 people, hotbed of innovation, my role is to support them kind of having some cohesion and coordination around that. The same is true of the community trust, the same is true of the mental health trust, and they've both got someone like me helping them to kind of bring that innovation to the fore. Primary care do not, because as we've said, there are it's a distributed business model under the NHS banner, isn't it? And the voluntary sector often don't as well. But that isn't to say that there isn't innovation within those two sectors. So the question is, how do you draw that out if there isn't someone like me working at organisational level to support them? And some colleagues who are in the room will know one of my kind of pet peeves over the past kind of 12 months working in the space has been the absence of what I see as being a peer network. So I'm really clear about the national support offer, I'm really clear about the regional support offer, but there isn't a kind of peer network. So, and that's, someone made the point earlier, that's because innovation is held in different portfolios in different places. So there's not a natural network to go to. And the absence of that peer network for me as a trust is then amplified into primary care and voluntary sector where, but just by the nature, it's a bit more dispersed. So I guess then the question is, how do we facilitate that peer network? And for us locally, we've been drawing really heavily on the Health Innovation Network. They've come to our trust, they've presented, they've engaged with us, and we're really, really grateful for that. And what's called Sherpa, so our kind of health research partnership, has more recently started to step into this space now, and that could be a forum where there is a bit more collaboration around the innovation space. So I don't know that I've got an answer for that. It's a really good question, but I think we're beginning to see some signs locally for us that we might have a response to it.
Any final thoughts, Mindy?
I was just thinking about when you were just talking then, I just think you're quite right about that peer networking piece, because one of the things that we hear constantly as part of the NIA is how all our innovators learn from each other and learn to collaborate just because they've been speaking to each other. And it feels like, I know there are some primary care networks that do that, but there isn't that kind of vast ecosystem or infrastructure around them. And I feel like we need to support that kind of primary care being able to speak to each other because they're so disparate. I guess one of the things I keep thinking in my head is that you do need to start somehow funding that money that goes into secondary care, into primary care and community. One thing I worry about is that the government is going to do that in a really stark way, because it seems to be they want to jump before they create the infrastructure to do it. And it needs to be a very slow, incremental change, because you can't do that quickly. But if we're looking at prevention, it can't be done in secondary care. It has to be, and I wouldn't even say it can be done in primary. I think it's community care that needs to have that. But you need to create the infrastructure, and part of that infrastructure is that peer network, so they can learn from each other.
Paul, any final thoughts?
I think that my final thing to say would be, if you can think about how you define value, real material value, and work back from that, there is funding around. It's easier if you can demonstrate cash releasing in year savings, or you can tie it to a particular funding scheme like QOF, for example. It's easier if you can do that, but there is funding around, and so don't give up. We are a real hotbed of innovation in this country, and we've already heard today about the volume of things we're able to do. So if we can persuade enough people of the impact we can have and the value we can create, then the money will follow.
Fabulous. And Mike, a final thought or a final new word for us?
What, beyond pilotitis? No, I think you're right. It's a question of how we spend our money. The money's going to be fixed for quite a period of time, and money's spent elsewhere in the economy. But the life science industry is a great place to grow and get money. The 1.2 billion IQVIA, the 7.4 billion coming in from life science industry, 300,000 jobs in the economy tied to life sciences. The more you can do to work collaboratively with industry, the better it will help the economy. And if we do that, that's going to help spending in healthcare.
Thank you all very much. Will you join me in showing your appreciation to our 6 panellists?